Anyway, yes.
All right, thanks very much.
Thyroid, whatever you want.
An oid of some sort. Okay. So we're going to shift gears and talk about desmoid tumors here. So desmoid tumors are benign, locally aggressive neoplasms that derive from fibroblasts. These can be sporadic or familial. And they, despite surgery, radiation, or chemotherapy, there are very high levels of recurrence. So these are very difficult to treat tumors. In particular, surgery fails because I think that although the surgeons, when they get intraoperatively, they can see this very discrete mass, oftentimes there's this more subtle infiltrative component that's hard to completely resect. Focused ultrasound has emerged as a promising technology for treating these patients. The basis for treating them is essentially from our experiences using these types of devices to treat patients with uterine fibroids. As we see here, very effective for treating uterine fibroids, but important to remember that desmoid tumors are not the same as uterine fibroids. Here's an example of a focused ultrasound treatment for desmoid tumors that we performed at our institution. So you can see nicely here showcasing the high level of precision of focused ultrasound, able to carefully avoid the sciatic nerve in this case. Our research question, in light of the fact that we're using a device, the Insightec XAblate device that was initially developed to treat uterine fibroids, were which technical parameters contribute most significantly to thermal dose accumulation following focused ultrasound of desmoid tumors. So we retrospectively reviewed sonication data from an 18-month period of time at our institution and reviewed a variety of sonication parameters. I want to highlight one sort of towards the end of that list, dose efficacy. And by dose efficacy, I just mean that we looked at we evaluated qualitatively relative to the intended volume of the dose ablation, whether or not we ablated 0 to 25%, 25 to 50%, and et cetera. We then did some statistical analysis, so mixed effects models, trying to estimate the association between each parameter and thermal dose accumulation. And then linear regression models estimating the importance of each of the parameters to the total variance explained by all parameters jointly. Just a quick word on our sonication nomenclature here. So three main types of sonications that we're using. So nominal sonications, you can see, are typically 8 subsonications centered around a single point in the AP dimension. For a nominal 0, that's just a single subsonication. A short sonication is essentially very similar to a nominal 0. And then finally, an elongated sonication is several subsonications stacked in the anterior-posterior dimension. So results, we looked at 13 treatments over 18 months in 7 patients. Almost 1,000 sonications were reviewed. The average number of sonications per treatment was about 70. So a lot of numbers on this table. I just want to sort of highlight this, one of these first lines here in terms of the average energy that we were using for the different sonication types. You can see that the elongated is a much higher energy sonication typically compared to the short and nominal. In terms of the accumulated dose by spot type, you can see that the elongated led the way, as we would expect, given that we were using the most energy for those types of sonications, but followed closely by short sonications, and then nominal was behind both of those. In terms of the efficacy of different focused ultrasound spot types, we termed a high efficacy sonication any sonication that resulted in greater than 50% ablation of the intended volume. And you can see that the short sonications seem to do this more often than the nominal or the elongated sonications. For our linear mixed effects model, so what we were doing here is trying to estimate for a 1 unit increase in any of these types of parameters, so power, duration, energy, et cetera, how much additional cc's volume we ablated. And what's nice is we have some internal consistency here. You can see when you multiply power times duration, you get the same coefficient that we calculated for energy, as we would expect. And then finally, in terms of percentage variance, so about 44% of the intertreatment variability could be attributed to the variables that we looked at, and this is sort of our top 5 here. So spot energy clearly going to contribute significantly to variance. Roll maybe somewhat unexpectedly, followed by power, patient, average temperature. So take-home points here, variety of sonication parameters influence the ablation zone during focused ultrasound desmoid tumors, and hopefully this points the way toward future studies that are going to give us a better understanding of how to precisely design treatments for these patients a priori. And then finally, of note, elongated spots may offer relatively small incremental increase in ablation volume for the additional required energy. Thanks very much.
Questions for Dr. Bucknor?
Hey, Peggy.
Nice stuff. We should combine our data, by the way. Question for you. How did you account for the T2 signal intensity? It seems like that would impact the grading of the, how much dose you get. As you know, the lower the T2 signal, the more efficiently the tissue heats within these tumors. Seems like that would confound the grading system.
Yeah, so we didn't make a specific adjustment for the T2 hyperintensity, just thinking that hopefully over time with enough sonications, and again, that's a good reason why we should pull our data, we would adjust for that. Yeah.
Thanks.
Cool. All right, we'll keep moving along.